It's great to be here and to see everyone, a lot of friendly and familiar faces. I'm a child psychiatrist with St. Luke's, for those who don't know me, and also work with a lot of the great people that were on your case presentation.
Excellent. Thanks, Dr. Streeter. My name is Travis Haase. I'm a LCPC clinical manager here and work at developmental pediatrics and seeing patients. Neither one of us have any disclosures today. Go ahead and let's move to the next slide. So today I'm going to go through kind of the reason for irritability, some of the risks, potential treatments and interventions, and then we're going to drop into medications. I'm going to leave quite a bit of time for the medications for Dr. Streeter to really dive into those, as I know those are an important topic, especially for this cohort, as well as folks that are on here. Let's move on to the next slide. So what is irritability? There's lots of definitions here. I think we could add to irritability for all intents and purposes in this presentation. It's the tendency to exhibit uncontrollable anger and aggression. We're going to see usually irritability being increased or at a higher rate in our younger kids, but the severity will grow as they get older, and especially within our older males, that will have a higher severity if having this tendency is there for obvious reasons. Let's move forward. As I said, I'm going to move pretty quickly. So autism has lots of tendencies to irritability. Now, the criteria don't indicate specifically to irritability, but we're going to have these RRBs, these rigid repetitive behaviors that can elicit or trigger in a tendency to having this anger and aggression. You can have this restricted interest that lead to having to make a transition, and that triggers this out of control behavior or some emotional disruption. The self-injurious behaviors can occur, and those can lead to and have impacts to the patient as well as to others as their aggression or anger or emotional energy builds up. That can become more severe and impact their world, as well as the sensitivity to our sensory system that they will have in both hypo and hypersensitive, and then therefore create more triggers or potential tendencies to this. Move on to the next slide for me. And then you got your communication and social skills deficits, this reciprocity. All these create conflicts, barriers to communication, miscommunications that obviously lead to having more irritability or more anger, aggression opportunities. And then comorbidities kind of come along with autism. ADHD, anxiety, depression all have an irritability component within them. So having those in addition to autism puts it at a greater risk for this tendency as well. Next slide. So within autism, as you have more severity within that diagnosis, you're going to have a higher risk of that aggression and anger. And then in addition to that, if you have any psychiatric diagnoses, as you have a higher level of autism, that's going to increase that risk. And then in addition to that, if you have any other social determinants or biological factors, personality tendencies, social factors, those will all impact and increase that risk for that kiddo when we're looking across the spectrum. Next. So very, very, very important slide, crucial for working out irritability within autism, because there are so many variables and it can be super complex and everything can be intertwined, and we really have to get into the nitty-gritty of observation and to interview to really pull apart where maybe the irritability is coming from, where this tendency is higher than other times in their life. So, where our transitions have to be, what the day-to-day looks like, what environmental factors are impacting us. Do we have any family stresses? Do our parents fighting? Are there other psychiatric disorders, both with family or with the patient, that are increasing and potentially are the cause to that irritability or that frustration, intolerance? Physical symptoms, so physical illness. So as PCPs go, are there stomach aches? Are we constipated? Is there some pain that is occurring that's increasing this tendency that we're potentially having a severity of either hurting the patient or someone else? We A story I have that I think helps kind of pull out this assessment and pull out some of the aspects of assessing irritability. We had a couple of years ago, maybe even more than that, maybe 4 years ago, we had an ADEPT program come out of the Mind Institute at St. Luke's, and we brought in an ABA therapist, Patty. And Patty had helped us kind of put this group together, and she brought a story that she told us into the group that we had when she was working at a school, and she was an ABA therapist there, and she'd have students come with all sorts of different struggles, and she had a kiddo come with aggression and anger towards all these other students, and the school worked with her for about a full 2 months, I think, might have been a little bit longer, around trying to discipline and add, environmental structures, and they had tried essentially everything to try to stop this aggressive behavior occurring with the student. And as Patty worked with the kid, as ABA goes, they take lots and lots and lots and lots and lots and lots of data, right? Lots of data, lots of check boxes. And eventually, over time, you can start to take that data and kind of compile it into maybe where there's other triggers, or where it's more likely to have these other triggers. And one thing that Patty had found out was that around like times where the patient would have people around their face, or if they put their face down, or if they were playing games where things were being thrown, you would see this irritability and aggression occur. And so she told the parents that they should probably go see the PCP and get an ENT referral, or have the physician do a ear, nose, and throat exam. A couple weeks later, the family comes back and it's like, just by chance, the PCP looked up the nose, and there was one of those beads that they made necklaces with on the first week of school that had been shoved up this patient's nose and lodged in their sinus cavity for the last several months. And it was restricting airflow and blood, and obviously the pressure in there, the sinus pressure. This patient was nonverbal, or this student was nonverbal. And so she couldn't communicate what was happening. And so the school year starts, and everyone thinks that this kiddo is aggressive and angry, and they pull this bead out of her nose, and she wasn't angry and irritable, and was able to be taught and not have these consequences and disciplinary actions occur. So when we're looking at irritability, I feel like it's a really important symptom to really evaluate and get into the nitty gritty, because it can point to a lot of things that are occurring. And sometimes we'll overanalyze it, and it'll take us all these brains going into it, trying to be like, oh, it's this and that and the other. Sometimes it's literally a very simple solution of just pulling a bead out of their nose that then essentially takes care of this irritability problem. And as we look at everybody here from a PCP office, like that, it's real important to keep that in mind and to really assess that thoroughly. And we can move on to the next one. And so this story kind of also brings forward gaining and bringing in a lot of other informants, as I kind of talked about with Jessica too, is following up with folks that can help give more observation and give more data to what's happening. As you're going to first see the patient, it may not be obvious to what that trigger is, and it might take some time, but getting other folks involved, other professionals, can really help that evaluation process. and getting those other environments and areas observed and collected. Move on to the next one. The last slide for me, and then we can move on to Dr. Streeter. So interventions across that aren't medical, right, or that aren't medications. So as I said before, as you evaluate and assess, if you're not finding out the trigger, it's not super evident right at the beginning, refer out, get some OT, get speech, go to DVPEDS, whatever might be the most appropriate. Maybe they have a lot of comorbidities and you feel like maybe the ADHD and there's a mood disorder, so psychiatry might be appropriate, but just look at getting outside of that scope to help evaluate and assess that irritability. First priority within those interventions is safety, right? Siblings, how are siblings doing? How's mom and dad doing? Are they safe? Is the patient safe? Is there some major self-injurious behaviors that we need to focus on? Are the property, do we have any concerns with property or damage or the patient hurting themselves or getting out of the window? All those things need to be taken care of and be as a priority within our interventions. When we look at getting into counseling or getting into ABA therapy or OT, gold standard is ABA, especially when they're younger, because if you can begin at ABA really works well within that younger years to then build so that severity of 12-year-old kiddo now is not so aggressive and there isn't any of these major behaviors occurring. There might still be needs that need to be met, but our severity is way less because we were able to get that beginning early start to that therapy. Now, OT, speech, counseling, educational interventions, HI, BI, CBRS, all of those are obvious to me in the sense of getting in and getting those interventions started. As littles go, counseling can be a little bit more difficult, but PCIT, PM, so parent interaction therapy or parent management therapy are very suitable and capable of supporting parents and the child with dealing with irritability and how to manage that, how to manage their own emotional state. As I said before, as parents might have struggle, they're dealing with this on a daily basis. They might have a psychiatric disorder. They may be struggling to hold their own irritability in check. Counseling can kind of come in and help with that support, especially as they get older. Typically, those 12 to 16-year-olds that have pretty severe behaviors end up in the mental health field somewhere, and really trying to help manage them as best we can. Cognitive behavioral therapy is kind of the go-to there, but I think when you're referring out, if the provider's not working with the parents, I would want to be contacting the provider and kind of finding out what their strategy is, as the parents need to be involved in a lot of this, if not all of it. Dr. Street, was there anything else in there?
I don't think so. I really love your comments about the assessment piece. That is absolutely critical, and getting collateral information from as many people as you can, because I feel like, even when your patients are verbal, it can be difficult to, they may not have the same level of insight that you might expect for that same for that same age child. The parents oftentimes are overwhelmed and stressed and, may be hyperbolic, or they may also minimize, that they're stoic and, and sort of just toughing it out. And getting collateral information is super helpful. And in addition, it really doesn't feel good when you have a kiddo who's had acute on chronic sinusitis or eustachian tube dysfunction with sterile effusion that's just really hurts, or GERD that is contributing to behavioral, even for verbal kiddos. I've had a couple of kids in particular I can think of off the top of my head who had legitimate physical pain issues going on from other various reasons, and clearly exacerbating their baseline irritability which was fairly manageable. But then when they had exacerbations in like sinusitis, for instance, they were struggling. So yeah, thank you for all those comments. In addition, from a psychiatric perspective, there's and I know that I've mentioned this in other forums, but there's something called the treatment of maladaptive aggression in youth, which was a sort of a consensus work that was done that maybe one of our team can throw in there as a resource for neurotypical children, that basically goes through. There's guidelines that are developed, and they're developed for primary care specifically to kind of make an algorithmic approach to treatment of maladaptive aggression in youth. And the general rule of thumb with that whole body of work is that you really need to maximize your psychosocial interventions, both therapeutic interventions and social interventions, to support children before you pull the trigger on heavy hitting medications like risperidone or Abilify, aripiprazole. And the reasons for that are, as Travis mentioned, that they oftentimes the interventions are more appropriate to psychosocial interventions. For instance, if there's an adjustment issue, then you really want to look at a social intervention. If there's more chronic anxiety, then psychotherapeutic interventions can be beneficial as opposed to medications. But then also from a psychiatric perspective, as with everything in medicine, you have to know what you're treating. And so if you're going to use a medication for irritability, you really need to make sure that you don't have a co-occurring condition or comorbid condition. And part of that is because we don't yet have a medication or set of medications that treat the core symptoms of autism. Maybe someday we will have some variant of oxytocin or something that can help people with their attachment, that sort of generates the desire for attachment or improved attachment. But yet we just don't have that yet. So we're stuck treating symptoms, and it is so important to identify any comorbid conditions that you may have in addition to the irritability. As Travis mentioned, irritability is a named symptom of so many different conditions or disorders within psychiatry. It's a named symptom of anxiety, of PTSD, of depression in youth, of phobic avoidance, and social anxiety, and so on. So Autism Speaks, I think this guideline, I think, is actually pretty good for parents. If you have a parent that's kind of, you're starting the conversation, like you've done all of your psychosocial interventions, 6 months down the road, there's a whole team involved, and everyone is giving you feedback like, hey, we've got to do something for this kid. We are all stressed out. We're doing everything we can. We need some medications. I do think that this is a legitimate, bona fide resource for families to kind of look at, that I don't feel is biased one way or the other. Next slide. So again, is there a comorbid condition? Obviously, if you're looking at ADHD, which from my experience is highly comorbid with autism, then you're going to be looking at stimulants. Of course, stimulants can worsen irritability, especially if there's also anxiety. And so alpha-2 agonists such as clonidine or guanfacine sometimes can be helpful, especially more for irritability and impulsivity. Those medications, if you're not familiar with the mechanism, actually fool the brain through the presynaptic nerves to think through a feedback mechanism, to fool the brain into thinking there's a ton of adrenaline. And so your brain's like, whoa, people, we gotta calm down here. Otherwise we're gonna have a stroke or a seizure or heart attack. And that also will kill us. So it reduces sympathetic tone, and that whole fight or flight through that whole fight or flight mechanism. And so I think those medications can be really helpful. Obviously, they have their side effects. They can be sedating. They reduce blood pressure and heart rate. And so sometimes it's helpful, but you can't really titrate them to effect, as is the case with stimulants. Atomoxetine is another option, and there's a newer one called viloxazine. Those are both norepinephrine reuptake inhibitors. So they can work through those mechanisms. The effect size for those medications is not as robust. It's double or even triple. All of the non-stimulant options, the effect size, a number needed to treat inversely is between 6 and 7. So, and whereas with stimulants, it's about 2. So anyway, I could go on and on about treatment of ADHD. We see it so often, but maybe we'll have some time for questions. In terms of anxiety and depression, as we talked about cognitive behavioral therapy, if you have a high functioning kiddo with autism, even in school age kids, there are cognitive behavioral manualized therapies such as Coping Cat that can be really effective for teaching coping strategies, teaching self-regulation, deep breathing exercises, muscle relaxation, and so on, to help children regain some control over their anxiety. SSRIs remain the first line for anxiety and depression. SNRIs, such as duloxetine. Duloxetine actually does have the FDA indication for kiddos 7 to 17 for generalized anxiety disorder. I have seen it be very effective for depression as well. Then the vaccine tends to have a lot of side effects. So I do stay away from that, but sometimes it's a game changer for kiddos. So I leave it in the mix if you're backed into a corner. Next slide, please. So, in terms of symptoms, there is good evidence actually for at least clonidine and guanfacine by extension. But clonidine in particular has demonstrated efficacy for irritability for children with autism. Mood stabilizers, we sometimes will pull the trigger on Depakote or valproic acid, lithium. But generally, when I'm having conversation with parents, usually I start and say, well, I do tend to try to feel like, what would I do if this kiddo were my kiddo, my personal child? And oftentimes I will start with the alpha-2 agonists if there's not severe dangerousness, if there's not severe like self-harm where they're bruising themselves on a regular basis. Even though the evidence for risperidone and aripiprazole is probably better for those indications, I may go to that first, but oftentimes I'm trying to figure out if I've fully ruled out other co-occurring conditions, and this is strictly irritability associated with autism, then I do have that conversation with parents like, look, if this is really bad and we're thinking about hospitalization, or you're thinking about group home or alternative placement other than your family, then that to me is like an emergency, and we got to do something about that. So I will, in those circumstances, have conversations about risperidone and aripiprazole. Haloperidol does have some evidence, but the risk of side effects, including tardive dyskinesia and extrapyramidal symptoms, is higher than the second generation antipsychotics such as risperidone and aripiprazole. So I usually do go with the risperidone and aripiprazole. Maybe not a side note, but another note, risperidone does have better data, but of course, it's not tolerated as frequently as aripiprazole does. So I feel like risperidone on the whole is more effective, but does come with more risk of side effects. And you just see that in terms of prevalence. But aripiprazole sometimes is very helpful, and when it works, it usually works really well. Next slide, please. I can talk more into side effects down the road if we have time. Clearly, studies have shown alpha-2 agonists, as I mentioned, to be helpful, especially for hyperactivity and impulsivity, maybe not so much for inattention or focus. Stereotypic behavior, social interaction, again, it reduces a sympathetic tone. I did already mention the side effects. I didn't mention irritability, which I do see more commonly in children with autism, and I feel like that's and I don't know for sure. I don't know of any studies that have looked at this, but I feel like that's because children with autism already have such a hard time integrating their environment, from sight, sounds, feelings, taste, touch, and just all of that, that when you get just even a little bit of sedation, it just throws them off, and that makes them irritable. I've seen that with risperidone too, or aripiprazole. If those medications are supposed to help, but when they make the child sleepy, it just makes them cranky. And so, as I mentioned, blood pressure and heart rate do go down. And so you do, which is weird. You would think if blood pressure goes down, heart rate goes up, but that's not the case. It's actually both of those go down. So you do have to monitor that. Next slide. Mood stabilizers. When I do get backed into a corner, I will use carbamazepine, oxcarbazepine, valproate, lamotrigine, lithium. But that's normally after we've tried multiple other options and we're kind of backed into a corner. Oxcarbazepine doesn't require monitoring, neither does lamotrigine, but clearly there's side effects. I mean, Stevens-Johnson syndrome with both lamotrigine and oxcarbazepine, carbamazepine, valproate. I mean, that's a possibility with all of those. The prevalence is higher in lamotrigine, up to 3%, especially if you don't titrate it appropriately. So if you ever have any questions and you're thinking about starting one of these medications, I would recommend that you get in touch with PM and HMP or a child psychiatrist that has some experience with these, so that we can walk you through how to use them, titrate them, and monitor them. Lithium, the same thing. I mean, I have seen all of these medications be game changers for some kids, and I wish we could identify which kids are going to respond to which ones. I've seen kids do terrible on Depakote and then great on Trileptal, and terrible on lamotrigine, but for some reason topiramate works. And so I wish there was a rhyme or reason. Eventually there will be, hopefully, with multiples, continued studying of these medications and in children, but it's still it almost feels like a dartboard sometimes, which I hate to say out loud, but I mean, it's just a matter of trial and error until you find what works. Again, with attention to what the co-occurring conditions are. Next slide. Atypical antipsychotics, we'd already talked a little bit about risperidone and aripiprazole. They are both FDA approved. Risperidone down to 5 to 17, and then aripiprazole 6 to 17. But in practice, I have seen those be used at younger ages with appropriate justification and counseling, of course, with the family. Again, deliberate self-injuriousness, a danger to others. If you're looking, property damage is a indication. I mean, not an indication, but another consideration. Temper tantrums, if they're developmentally appropriate for the social and emotional age of the patient, even though they may chronologically be older, you have to take that into account, in addition to moodiness. And again, you're going to be, anytime you're thinking about using these or actually using these medications, you're really going to want to continue your collateral information and team building with speech and language, occupational therapy, PT, and your ABA therapy, your HI therapists, and obviously the parents and the patient. I mean, they oftentimes are a great partner in these treatments. But anyway, next slide. Yeah, I will say in terms of long-term use, yes, we don't have great data for long-term use. Oftentimes, children, when it's effective, are on these medications for months and years. And so we do know that sort of helps us in our monitoring. I mean, we have to really pay close attention to how kiddos are metabolizing these, if they're having increases in hemoglobin A1C, cholesterol, triglycerides. And so monitoring is very important. Next slide. In general terms, I think it's important to start low and go slow. You have to be methodical, considering safer alternatives, especially having trials of therapies to support frustration tolerance, coping strategies, communication, which of course is a really big factor in irritability, and then monitoring. The monitoring is important. I don't know that I have a slide specifically on that, but generally for the atypical antipsychotics, you're going to want to get a baseline CBC. Usually I'll get a baseline CMP as well, because if you start to have metabolic concerns, you're going to want to look at transaminases or any sort of fatty liver issues or other metabolic factors. And then also a hemoglobin A1C and fasting lipids as baseline. Oftentimes I will also get an EKG, if not always, just to make sure that, especially as you get to higher doses, you're not causing any QTC prolongation. And then in terms of tapering, I usually start having conversation with families about the 6-month point and say, hey, even for severe aggression, studies have shown, you really should consider, and practice guidelines recommend that you consider a taper annually at least. Usually families are like, don't touch the meds, we do not, we're finally sleeping all night, we're finally going out to the store, and we're having some semblance of a normal life. We do not want to reduce this, but generally I document that I do discuss it at least with them and that they would like to continue. Next slide. So as I may have mentioned Haldol or haloperidol in the past, olanzapine, I will use those. Ziprasidone sometimes is used. I've had a couple of kiddos with autism do great on acenapine, which is otherwise known as Saffris. It's just, but typically I will start with the FDA approved. Well, I always actually start with the FDA approved medications. Next slide. Yeah. Oh, can you go back to that slide? Actually, I think a really important point is there's clear data that if you're going to be doing a medication, you must be doing behavioral treatments. I mean, it's really wrong, in my opinion, to just do medications and not be at least trying to do something else to support other advancement and an improvement. So next slide. So yeah, and it looks like I do have some slides on this then. Sorry about that. So the definition of atypical doesn't mean that it's abnormal in any way, but it's really just that they're less likely to cause acute dystonia, akathisia, Parkinsonism, tardive dyskinesia. They still happen, and part of my monitoring is to do an abnormal involuntary movement scale, which is a free online PDF that you can just kind of work through at least annually if you have a patient on these medications. I usually will do one at baseline and then annually. But if a parent complains of any abnormal movements, I will do one at that visit, even if I saw them 2 or 3 months ago. The more important side effects are going to be weight gain, which of course compound the possibility of increasing cholesterol and triglycerides, type 2 diabetes, and it is higher in female and then older patients. So I think it's important to look at that. I mean, obviously the anticholinergic side effects, especially with medications like olanzapine, you're going to be having constipation, fatigue, drowsiness, sometimes drooling. I've seen drooling even with risperidone, which doesn't have nearly as much anticholinergic effects as olanzapine, but there it is. And then the big bugger with risperidone, elevated prolactin, which of course can cause galactorrhea and gynecomastia even in males. I have had that be an issue for females more frequently, but the gynecomastia is something that I've seen in males. Next slide. So for monitoring, I've already mentioned some of the monitoring baseline. I actually do every 3 months for the first year, and then I'll do 6-month intervals for the next year, and then I'll do annually. I've been surprised, sometimes I'll get a CBC after 6 months, and it'll show an ANC of, 1300. And I'm like, wow, how long has this been going on? So it sometimes, and of course that could be just because the kiddo had a viral illness in the last couple of weeks, and so we'll work through that. But sometimes it is the medication, and I'm not sure. Well, at least, presumptively is the medication. We don't know for sure. So sometimes I will taper medications if I have a problem with that and go with something else. Obviously, tics, twitches, tremor are things that you're going to be monitoring. I usually don't modify treatment if you just have someone with a really fine tremor. But if they're they can't eat because they're having difficulty with their tremor, then I'm going to either try to treat that or change medications. For risperidone, I do check prolactin. If it's in my conversations with pediatric endocrinology, if it's above twice the high normal, then that's probably time when you really need to change, a medication. Next slide. If I do have, just as an afterthought, if I do have someone with weight gain, I'm starting that conversation when they have 5 or 10 pounds of weight gain in terms of diet interventions, food security, making sure that kiddos have healthy options. But sometimes it becomes a major issue, and that the hunger itself gets so severe that kiddos are having to come off the medication because that's making them irritable, even though the medication may be ostensibly helping them. So in general terms, as I mentioned, start low, go slow, and you have to be, especially if a child is nonverbal, super methodical and give medications time to really kick in. For the atypicals, usually 2 to 3 weeks would be enough time to see some change. But if it takes 2 or 3 weeks to make a change or at least get to a plateau at that particular dose, then you need at least another 2 or 3 weeks for parents. And if they have different homes, if parents are divorced, then you want data from mom's house and dad's house. You want data from the school. You want enough visits with speech and language and OT and PT to really give them time to see a change before and you're also observing a patient and seeing if there's a change. Sometimes it's miraculous, sometimes it's night and day, but other times it really does take time. And so be super methodical and systematic, be patient, think long-term, always on the lookout for side effects, always on the lookout to discontinue it, and really rely on those psychosocial interventions. A lot of times I've seen medications just get you over that hump so that children can actually participate in their therapies, and then they start helping, and then you can taper off medications. Be prepared also to go back to a medication that was previously ineffective, unless of course it was like a major side effect. If kids are throwing up, 5-6 times a day on a medication, you're not going to want to try that again. But anyway, it's okay to rethink previous medications as fair game potentially at a later date. Next slide. I think that's it. Does anyone have any questions for Travis or I?
Anything in the chat from anyone else? Did anyone see any chat questions?
I haven't seen any chat. I don't know if anyone else has been following that, but I don't see any chat. Thank you both very much. Such a good sprinkle of information, and something we've all been hungry for is something for our older kids, even though we're focused on the younger kids. So I'll pass it on to Mike Aldis.
So any comments about pharmacogenomic testing?
Hey, thanks, Mike. Good to see you. I can speak to that. It's pharmacogenomic testing is basically looking at the CYP450 enzymes in the liver, right? I mean, there's some other tests that they will look at, such as MTHFR, methylfolate hydroreductase. Sorry, I'm not getting that right. But there's, pharmacogenomic testing may give you some other sort of offshoot, but essentially it's looking at CYP450 enzyme systems. So it's going to tell you if a medication is poorly metabolized or rapidly metabolized, or ultra rapidly metabolized, actually. And so in the first case where it's poorly metabolized, it's more likely to build up in someone's system and therefore cause more side effects. In the later case of ultra rapid metabolism, it's possible that medication may not get to a therapeutic level to begin with. That being said, I've been backed into a corner and had the experience many times, well, I should say a few times, where we try something, we're like, hey, we gotta do something today, but let's also get this testing. And they come back, 4 weeks later, and the medication that we chose was in the red level, or in the red zone, but it was working. And so it's not going to tell you, even if a medication is in the green zone or appropriately metabolized, if that medication is going to be safe or effective. It's still somewhat of a crapshoot of whether or not that medication is going to work. But at least it gives you a good idea of what to look out for. As well, the medications that are in the green zone may still have some severe side effect that the patient may experience just normally, because even though they're normally metabolizing, it still can possibly cause a problem. Does that answer your question? Yeah, I would say I usually reach for that whenever I've had some really weird side effects that I don't ever see or don't anticipate based on the receptor binding profiles of the medication. Or if I've done multiple medications and someone's not responding. So I will get it. I just am mindful about the utility of it.
So it would be more about dosing than selecting specific medications.
Yeah, and the other really, really helpful aspect of it is that it will tell you, let's say someone has a 2D6, CYP450 2D6, that they're a poor metabolizer. Well, I mean, like any medication that goes through that pathway is going to be poorly metabolized. So for instance, fluoxetine and aripiprazole both go through that pathway. And already, fluoxetine and aripiprazole will compete with each other for that enzyme. So they both build up in your system if you add one to the other. And let's say I want to add propranolol to the mix. Well, I wouldn't, because I know that they're a poor metabolizer for that, and I don't want to throw them into third-degree heart block. With, if I give them propranolol, it's just they're going to go into junctional rhythm on me or something. So that's kind of how I approach it. It is really useful, especially when you get into polypharmacy as well, and you're looking at drug interactions.
Can I add something real quick? Thank you, Dr. Ellis and Dr. Streeter, that for those who are not medical, like my non-medical folks that are on this, don't sell that as like, have your doctor go do this test, because we're not thinking that the medication's working or something like that, as that has happened in the past, and it sets the doctor and it sets the patient up for some struggles, as that's not what that is indicating or identifying. Alicia, sorry.
Yeah, hi. Thank you so much for this talk was outstanding. It was really great. And I just have a quick question about the side effect with sedation with clonidine and guanfacine. And that's often the side effect that leads my patients to, or the parent at least, to, say the sedation was so heavy that they decide to DC the med, but they don't give it a long trial. I'm just wondering if that's a side effect that you expect to decrease over time. Like, would you, of course, starting at a very low dose, but would you expect the sedation to decrease over a week or two of taking the medication?
Yeah, thank you. That's a great question. I don't often see people get used to it. I have seen it. I have seen families just kind of power through it, and a week or two later, they're kind of used to it. Generally, I'm looking at dosing, sort of the administration aspect of that, where I would recommend to give it, like, for instance, if they're taking it in the morning, obviously we'll do it at night. Clonidine ER and guanfacine ER have a Tmax of about 6 hours. So, it's going to be it's going to be at its peak in their system at the 6 hour mark when they're sleeping, but at the same time, it should last well into the next day. The half-lives for both of those medications are anywhere from 11 to 17 hours, depending on age. So that some of it will continue into the next day. So I try to give the majority of the medication at night. Sometimes I will go to the IR formulation if they have a really really robust sedation with those medications, so that they're not as sedating in the morning. And I also try to give it to those kiddos earlier in the evening, because it's so much easier to be sleepy at night or groggy at night than it is in the morning when you're trying to get to school and all of that. I will do like so I do the majority at night. I try to divide it BID as much as possible, but I will, sometimes I'll do like 75% at night and 25% in the morning. Yeah, I try not to, they're both in the IR formulation intended to be BID drugs. So I really try hard to balance it out as best I can. But sometimes, I've had some kids just on 1 milligram of immediate release guanfacine at night, and they see, that's worked okay. But generally, I'm trying to go for the extended release formulation. And if it's just too sedating during the day, then I'll do the IR. And if that doesn't work, then I'll just try to go down on the dose. But generally, if it's going to be sedating, I find that it is just sedating. I've only had a few patients tell me that they actually got through that successfully. Maybe other people have different experience.
Just to add to that, I've had some families say, Alicia, that after starting the medication, the child was pretty sedated, like the first or second week, or a little bit tired, maybe falling asleep in school. Sometimes they'll say like the third week was great, and then the fourth week it's not working as well sometimes. So I always just tell families, give it a good 4 weeks, right, before we make any changes or decisions. And I always start, as Dr. Streeter said, start low and go slow. So sometimes we're just at the lowest dose and it's not really doing much, but they do feel a little bit tired. But yeah, give it a good 4 weeks is what I usually say.
Yeah, thanks, Dr. Francis. I appreciate that. Looks like Brittany has a question.
Yeah, before I speak to my question, I can kind of verify that, Dr. Francis, my own child takes guanfacine, and that was our effect. He had that sedating effect for the first 2 or 3 days, then got better, then was great. Then it seemed to not be as effective. We went up to 2 milligrams of the ER formulation. He's been on that for several months and has done fantastically. So yeah, I always encourage parents to kind of power through. But my question was in regards to all of the complementary and alternative things that are out there. Is there anything that you have found data behind, or anything that you do recommend people, like omega-3 supplements, magnesium, any of those kinds of things that you do think there is value in?
Wow, that's a great question. I'm looking at Dr. Francis on my screen to see if she wants to help me with this. The data, it depends on the indication, so, limited data for omega-3s and depression, ADHD, limited data for vitamin D and depression. I think, when I'm talking to families about this, I usually will say, what is our goal? What are we really hoping to achieve? And I talk about safety and efficacy data that medications have. There's none that I feel are as effective as medications. I don't know about safety, because that's a whole nother. That's why parents, I think, are interested to do over-the-counter supplements. N-acetylcysteine, or NAC, has limited data for aggression. I've seen that be effective a few times, but not so often that I reach for it right away. Let's see what else. Yeah, I've had people come to me with ashwagandha, say that it was amazing. Oh shucks, what's the other? I'm not thinking of it right now. But yeah, magnesium, I've had many patients on that I didn't prescribe it, but the parents felt like it was helpful. And so a CBD is another one where I'm like, you got to be, I don't recommend that actually, because it can be adverse, but it's really, I guess I just restrict my practice to generally talking about medications. And I tell parents, if they're going to be doing over-the-counter things, that's going to be at their own risk. So Dr. Francis, do you have thoughts on that?
Yeah, I agree with what you said. I always, Jessica, you put diet in there. Perfect. That's exactly what I was going to say. Most of these kids are very picky eaters. So get a good diet history, get a good sleep history. If they're low in iron, they're going to have restless leg. If you're not getting enough sleep, they're going to be cranky and irritable. So it's always important to kind of think about that. And I would love for every kid to be on a multivitamin, and then consider iron if you think they might be low. Do iron studies and double check ferritin.
Yeah, thank you. That's great. Yeah, great comment. And actually, ACAP practice guidelines, at least for ADHD, do recommend that it's still reasonable to get a CBC and iron or a ferritin for evaluation of that in ADHD. One comment getting back to clonidine and guanfacine, what I have seen a lot of times is where kids will have a sleep debt. Like they're not sleeping well, and you finally get them to sleep, and then they sleep really too good, for like several days until they get through their sleep debt, and then. So maybe that's what was happening before, but I generally, if the medications are like really sedating where people are like almost drooling on themselves, then I don't see that go away too often. Tom? Oh, you're muted.
This is what being up all night does to a man. I was wondering if you could comment about using guanfacine with, say, like methylphenidate and the increased risk for tachyarrhythmias. I see this commonly with kids that I assume care of, and I typically prefer Vyvanse, where you don't have that same risk of a tachyarrhythmia, is my understanding. Can you comment on that?
Yeah, there's actually a long history behind this where methylphenidate in Canada was actually taken off the market for several months. I want to say it was in the early to mid 90s, maybe. But in any event, this started off a systematic review because they had several sudden deaths in children. What they found was that there were either there was a structural cardiac abnormality that was previously unappreciated, that they had a family history of arrhythmias, or that there was a family history of sudden death at an early age, less than 35. And so, the ACA, I think the American, or is it AAC, American Academy of Cardiology, or ACA maybe, came out in like 2007 and said, any kid on a stimulant needs an EKG. And then they revised that later on to say, well, hey, if you do have either personal history of any arrhythmia or structural cardiac abnormality or so on, or a family history of those things that I mentioned, to get an EKG at baseline to assess. The kids in Canada were on methylphenidate and clonidine, but guanfacine ER and clonidine ER both were studied with stimulants, and they are, it's reasonable to prescribe those with stimulants with those caveats. So I think that's my practice, is that I investigate that thoroughly. If I have any question, even if Aunt Susie, had AFib in her 50s, I usually still will get an EKG just to answer the question definitively, and take it from there. And if you're combining medications like a stimulant with risperidone, for instance, even more reason to get an EKG. Did that answer your question?
Yeah, I had read some information that Vyvanse was preferred over methylphenidate and lisdexamfetamine versus methylphenidate because it didn't have that same risk factor, and I just didn't know if there was science behind that. And it sounds like the methylphenidate is kind of a ghost from a misinterpretation of some sad situations.
I think so. That's a good. I'm not sure if you want to send me that reference, I can take a look at it. But I haven't seen that in the literature, at least the child psychiatric literature that I look at to verify that for you. So I'm not sure why Vyvanse over methylphenidate.
It didn't make sense to me.
Yeah, I don't. I just consider methylphenidate and the amphetamines to be similar in that regard. So, if I have a kiddo with, mom had PSVT in her 20s, and or it was on digoxin for a while, I generally am going to get an EKG, even if I put him on Vyvanse, put her on, the kiddo on Vyvanse.
Great, thank you.
Sure.
Thanks for this conversation, and for those of you that hung out for the extra sprinkles of that knowledge burst, thanks so much, Chris and Travis, for your presentation. Our next session will be Thursday, January 25th, and that will be from 12:30 to 2 Mountain Time. The topic is medical follow-up with children, or for children with ASD, and the presenter is Dr. Tom Patterson. So thank you so much. I will see you on the 25th. Take care.